Hi, everyone. Welcome to today's webinar. We will get started at the top of the hour in just a few minutes. Um, Want to make sure that the chat is working. Um, Please feel free to introduce yourself in the chat, including your organization and where you're located. Welcome, Beth. Nice to have you here. Welcome, Aaron from Pennsylvania. Glad to have you. Welcome, Cassie and Shauna. It's good to have you here. If you're just joining us, we're just asking people to go ahead and type your name and location in the chat. Let us know where you're joining us from today, and we'll get started very soon in the next 2 minutes. All right, it looks like we got a couple people from Access here. Welcome. Welcome, Michelle and Laura. We got some folks from the Chicago area here. So welcome to Anne, welcome Jamari, Maria, Chloe. Good to have you here. If you haven't mentioned your location in the chat, feel free to do that. And we are right here, right where we need to be at the top of the hour. So good afternoon to some, good morning to others, and welcome to today's webinar. My name is Travis Atkinson. I am the Chief Experience Officer at TBD Solutions and also a board member of the Crisis Residential Association. And you are here for today's webinar called In Good Hands, Care Coordination Across the Crisis Continuum. This webinar is being brought to you by the Crisis Residential Association. And CRA exists to support the operational and clinical functions of crisis residential programs around the world. Rooted in the values of empathy, recovery, and continuous improvement, the association seeks to connect providers with the best ideas in behavioral health treatment to transform the way people receive mental health care. Learn more at crisisresidentialassociation.org. A few housekeeping items for today. Obviously, we've got the chat that is going strong. Feel free to use that to share your reflections, to interact with other attendees. But also know that it's best to use the Q&A feature in order to propose questions that you might have to our panel. My colleague Marty will be monitoring the panel today. Excuse me, not the panel, but the chat, the Q&A. So if we see questions that come up, we will try to insert them either as we're talking, if it's relevant to the topic, or at the end of the webinar today. So feel free to submit those at any time. The webinar recording will be made available to everybody. Members will get a copy of the slides from today's webinar, as well as immediate access to the recording. And then those who are non-members of CRA will get access to the recording about a week from now. So just a little bit of a delay, but that is a benefit that we offer to our members to have immediate access to those resources. So I'd like to move us into our discussion today by talking about the ideal behavioral health crisis continuum. Now, this has been a topic that's been very near and dear to those of us who work in crisis services for as long as we've worked in it, but it's been receiving a lot of national attention, I would say, for the last 10 or 15 years. And we know that behavioral health crisis services have been built out of the safety net of services that were initially designed to respond to medical emergencies and other emergent issues. And so from police and fire and EMS and emergency departments, we have moved away to build out a continuum of services that meets people where they're at. And depending on where you live, your community might have one of these, or you may operate one of these services, whether it's a crisis hotline, a mobile crisis team, a crisis residential program, a 23-hour crisis stabilization unit, a behavioral health urgent care, an emergency room, a peer respite, a psychiatric hospital. All of these play a role or play a part in helping support people who are experiencing emotional distress, experiencing crisis, experiencing suicidal thoughts or ideations. And when they work well, they're all interconnected. But we know for many communities, these services are not all run by the same organizations. They may be disparately located across a city or across a county. And you, as a crisis provider, inevitably have to interface with other behavioral health providers or other crisis providers. And that can be really difficult because you may not be in control of the factors that go into play with how well those partnering agencies work with you. And you may be looking to create a discharge plan or to transfer somebody into a different service or refer someone into a different service. And that desire alone isn't enough to make it go well. And so we have put this panel together today to answer what comes up often as one of healthcare's or crisis services' most important questions. And that is, how can we be the most helpful? How can we not only deliver an excellent crisis service, but how can we connect the person that we've been working with or that we served or that called our hotline in a way that assures that they get what they need, not just what we're in control of, but also what our peers and our colleagues are in control of. So we are excited to dive into this conversation today to have a robust discussion about what care coordination looks like across the continuum. And to do that, we've invited three panelists, all with their own expertise in the crisis continuum, to share some of their experiences, both from the places that they've worked as well as the places that their organizations or associations represent. So we have three wonderful panelists with us today. Michael Redding with the International Council for Helplines, Jason Renaud with the American Mobile Services Association, and Myles Stickle with Netcare Access. So please feel free to turn your cameras on, gentlemen, as I introduce each of you. So Michael Redding holds a Master of Science in Community Agency Counseling from the University of Memphis and is a national certified counselor and licensed mental health counselor in Washington State. He has more than 25 years of experience in the King County Public Mental Health System, specializing in crisis services for individuals living with severe and persistent mental illness. Michael currently serves as the Executive Director of the International Council for Helplines and is an accreditation examiner for the organization. Welcome, Michael. Jason Renaud is the administrator of the American Mobile Services Association. He is a nonprofit consultant focusing on program design and leadership, a well-known public speaker and writer on recovery from alcoholism and the experience of people with mental illness. He is an active advocate for people who have fallen through the public safety net. Jason is also the board secretary for the Mental Health Association of Portland and is the organization's voluntary managing director. Myles Stickle has over 35 years experience in the community mental health system. He has worked in all levels of care as a provider, supervisor, and director. As a social worker, he challenges programs and systems to become more inclusive, innovative, and cost-conscious. He has been called out as being too client-focused and too aligned with staff. He is newer to residential services and wonders how it took him so long to get there. So, Michael, Myles, Jason, pleasure to have you here. And we are going to move right into our first question. What are common care coordination issues that happen between your line of crisis services and the ones adjacent to you? So I want to pose this question to Jason first. And Jason's organization represents mobile crisis teams and mobile service providers. Jason, from the perspective of mobile crisis, tell us about those care coordination issues that happen between those services and other ones that are adjacent to it.
Thank you, Travis. Mobile crisis is kind of stuck in the middle here. We're dependent on dispatch and crisis call lines to get notice of a crisis occurring, and then the most important is that we need a place to take people who need to leave where they're at. And so we're right stuck in the middle, and coordination between these two is key and developing. It's not a mature state at this moment. Some situations it's a local crisis line, some it's 988, some it's 911. Some cities use 311. It's a whole variety of different dispatch modalities. Second is that all across the country, we just don't have places to take people that are safe and secure. We don't have peer respite in all communities. We don't have good access to psychiatric services, to residential psychiatric services. So we're stuck in the middle. That's where we're at.
Okay. So Jason, if a mobile crisis team, one of the ways that people define that a mobile crisis team is doing its job is if it's able to divert people from unnecessary, expensive, and sometimes coercive services. But what I hear you saying is if if the team is good at stabilizing, but they don't have places to refer, then that might impact their ability to divert people from, say, the psychiatric hospital if residential crisis or peer respite services don't exist.
Well, that's right. And the assessment always happens at the scene. Can we leave a person in place safely, or do we need to take some place? Sometimes a person just needs to be taken to a local shelter. Sometimes they can go to a church day center. Sometimes they need to go to their sister's house. It's all different, but having crisis stabilization services is extremely important and a resource we're always looking for.
Okay. Miles, same question over to you. You work in crisis residential services in the Columbus, Ohio area. Tell us about the common care coordination issues that happen either receiving a referral from a person for a person or trying to get them discharged into the next level of care.
I think we all have like a limited amount of time with each person. And so when I think of Jason's example of like trying to get someone placed who's out in the community, I think one of our challenges is we have to have time to review that information. And, we have to have a doc approve the admission. And, Jason's out there in the community and this has got to happen like pretty quick because they've got another run to go to. And we might have, criteria based on our current milieu of like who we can accept and who might be more challenging for us to manage. So part of that gathering of information and the time it takes is I think one of our challenges that we need to work on, that we continue to work on. Um, yeah, I'll start with that.
Okay. Michael, same question over to you.
Thanks, Travis. For me, I think from the crisis helpline point of view, I think just looking at the whole continuum is so important to the helpline because when somebody calls and talks about what they're going through, the intention is to really meet that person at the least restrictive level possible. So hopefully that phone call is going to meet their needs and meet that person in crisis and give them a plan to move forward. For some people, it's not enough. And so that's where mobile crisis comes into play and, crisis facilities as well. So the coordination on behalf of crisis helplines is to really know those other resources and make those connections. I think the onset of 988 has really underscored the importance of that by talking about somewhere to call, someone to respond, and a safe place to go. And so what I've seen across the country is a lot of states are emphasizing more the continuum and not just the 9-a-day call center. And so 9-a-day call centers do have a responsibility to dispatch mobile crisis. So setting up those systems that there's a seamless coordination effort from that phone call to the mobile crisis team, sharing information, being as efficient, as effective as possible, so it's timely. Um, and for some people, that mobile outreach might not be enough or might not be timely enough. And so knowing what those residential facilities are that can handle people in crisis that are not hospitals and not emergency departments, that could actually have the right people in a facility to maybe know where they are, local to the caller, and be able to set them to. So all of those coordination efforts are so key to the crisis helpline, and knowing those resources and those partners are important.
Okay. I want to bring this question even in a little bit deeper, Michael. So we're aware that 988 centers across the country really try to answer as many calls as they can, and that states care about their in-state answer rate. But sometimes calls get sent or pinged over to national backup centers. How do those 988 backup centers maintain awareness of the care coordination needs when they might not even be located in the state where the call is coming from?
Yeah, and that does happen. I mean, I know I'm in Washington State, and they very much, like you said, are very focused on in-state answering calls so that they can connect people to those local resources. I think that the whole 988 system, there are designated backup centers for 988. So when calls do roll somewhere, they're going to go somewhere else that could be out of state and certainly out of the region. So they do have, I think that's where Vibrant comes into play with like supporting the entire network across the country so that there are those resources available to the backup centers so that when they know if someone's, bounced from Seattle to Philadelphia, the folks in Philadelphia have a database of knowing like what's the back end phone number to call in Seattle to get that connection back? How do they connect people to that local resource when they clearly can hear this person can benefit from mobile crisis response, but Philadelphia and Seattle, they have no idea how to make that happen. So Vibrant supports that so that the backup centers have the tools that they need.
Okay. I want to ask a similar question to both Miles and Jason. What happens if you receive someone who's outside of your county, maybe even doesn't live in the state? How do your crisis services adapt to those challenges so that they can still get what they need? Because maybe they came from a rural community, and this is the best mental health crisis care that they're going to get or that they could have gotten in the state, and yet there's still something else that has to happen.
Go ahead, Miles. I'll follow you.
Yeah.
Thanks.
Okay. So in terms of out of county, that's not an issue for us. We do have funding through our board, but also we can bill insurance if need be. Um, Folks out of state, that gets a little more tricky because of insurance rules. But we always look at like who the person is that's here, what are their needs? Are they someone who's going to stay in this community? And so then we look for the resources here locally for them. If they're going back to their community, if that's a possibility, and we can figure that out during our, collateral checks, then we'll build services for them back there.
Okay.
So for the most part, mobile crisis and alternative response, two different models, are seeing people without regard to their home location. They're in crisis, they're here, they're now, we're going to help them.
Okay. And that's kind of where you keep the focus um and your priority. You're
Yeah.
help first, ask questions later.
Yeah, we might not get to the questions actually. Sometimes we help people we don't get to know who they are.
Okay. All right. The next question is, how do you innovate and practice exceptional care coordination in a fast-paced or unpredictable environment? Let's start with Miles on this question. And Miles, while you're getting unmuted, one thing that I want to touch on is that um, I'm aware that Netcare Access has had these exceptional kind of like care packages that are brought to individuals either right when they come in the program or right as they're discharging. Um, and maybe it's that level of thoughtfulness and hospitality that goes into these innovation practices.
Yeah, so I mean, one of the things that I talk with my staff about is that this is public mental health, but I want this to be a place that people are coming to and finding some benefit, and that it feels like it's a place of respite, that it doesn't feel like it's and public. I'm just using the idea of public mental health is like not necessarily a great place. So that's unfortunate, but I want it to feel elevated when people come here. I want it to feel comfortable and like it's a place that they can, relax and, nourish their bodies and nourish their minds. And so we make sure that we have some of those basic comfort items around. We've been trying to soften up the space as much as possible so it feels less clinical. Um, you know, it's those sorts of like value added things that make people feel like this is a place where they can really let their guard down and connect with what we have to offer. And they're back to that. They're only here for a short time, so they're moving through pretty quickly. So we need to get there as fast as we can.
Hmm. Okay. Jason, trying to get into the window of a mobile crisis team.
Sure.
They're getting dispatched maybe by 988, maybe by a centralized call center, and they maybe have a number of people that they might need to see in a day. How do they keep the care exceptional between providers when there's so much going on and it could just feel overwhelming, all the details, and not to mention the person who's in crisis.
Yeah, well, I think it all comes down to the individual person providing the care in mobile crisis, their experience, their integration with their community mental health system, their integration with social service resources is their primary tool, and that's not taught. You can't teach this. You have to learn this on the ground, and you largely learn this from experience. But it's also what draws people to this work is the variety, the problem solving, the being nimble, being smart about how your service system works. Unfortunately, this also makes it that a mobile crisis worker who learns the trade in Sacramento is not going to be very helpful in Los Angeles. They're just the information is so provincial, so localized that it has to be learned one person at a time. And this is both the strength and the weakness of mobile crisis is that care coordination really can be hampered with high turnover, low retention. You can do training about it. You can tell people, you can give them the resource guide, but it's like the experience is what's going to make the difference.
So, who do you think is responsible then for keeping the exceptional care coordination intact? Is it the mobile crisis workers themselves in pursuit of resources and developing relationships? Is it the supervisor of the team, or is it somebody at the leadership level of the organization?
Well, I think the clinical director makes a lot of difference. They're going to be your key resource, but mobile crisis workers are going to also ask everyone around the problem, how do I find the solution to this? It may be a family member. It may be a prior treatment provider. It may be a hospital nurse. It's going to be different each time, and that's what really makes it exciting. People who like to move fast, like to be nimble, like to make decisions, this is the work for them.
Okay. I want to open up a tributary of a question to anyone on the panel, and that is what happens when the place that you would normally refer the individual in crisis that you're working with is one that does not have a good reputation in the eyes of the client or the person being served? How do you navigate that when maybe they're open for services, maybe they have insurance and they could go to this, and yet it's left a bad taste in their mouth? How do you adapt in within these crisis services to make sure that they're still getting uh, good help or good care?
Well, I'll go with this one. If you're in a big city, the problem is pretty easy. It's you put it in the hands of the client, you put it in the hands their hands. Say, what's been where did you get the best experience, and we'll just go there. If you're in a rural area, though, where services are limited, this is really what makes it hard. When someone's had a bad experience at a hospital, when they've had a bad experience at a shelter, or when they've been 86th. Let's be frank, this happens. They can't go back. That makes it really difficult.
What does 86 mean?
They've been told they can't come back.
Hmm. Okay.
And whether that's true or whether that's in their mind, it's sort of irrelevant. It's what their perception is where you're working with.
Okay. Miles or Michael?
Before you'd ask the question, I was going to just mention that I do think it starts with finding out what the client wants. Um, many times when I do supervision with staff and they're talking about some of their struggles with where the client's going or what they think the client ought to be doing, I take them back to what was when they came in the door, what was their need? What did they want to do? If we're veering from that and we're taking them in a direction that's based on our values and our needs, then it's going to be that much more of a struggle. But if I partner with them and work with them on where they want to go, um, it's far better. I also live in a city, right? So we do have more options than folks do in rural areas. But I still think even when I worked in rural areas, it's important to listen to and include the clients that we're working with in all facets of the decision making.
Yeah, I guess for me, Travis, I think about that question, and I like what Jason said, where, there's a lot of factors go into what makes it like, less than quality care because maybe the client has something to do with that as well. And so they're kind of like put on a list. There's a frequent flyer type of thing, the familiar faces, the familiar voices. For me as a helpline, it's so important to just hold the person at the center and listen and be patient and practice that non-judgmental listening. Um, and that takes practice. I agree with Jason. Not everyone's cut out to do that. So it takes a certain person to do that crisis helpline type of work, to be a mobile crisis responder, learning from the experience. And I know my whole experience in behavioral health is like learn from the client. Let them teach me how to support them. When it comes to connecting to a crisis service, like in my region, when the helpline is referring to a mobile crisis, there's two providers in the community that do that. So that's it. So they may have had a bad experience with one of them, but that's the provider that's going to respond. So holding that space to support the person, listen, and let them know that like we care and we're going to respond and do what we can to help them, and try to get past the bad experience to hopefully get into a good one.
Sometimes you can reframe it by saying, is it the organization that you're against or the person that you came in contact with last? And it's unlikely that the person you came in contact with last is going to be the person you come in contact with this time. Sometimes
Hmm.
you can reframe the question.
Okay. But some of these activities to what I hear each of you saying is to really listen to the individual you're serving, really understand their needs, and have some sort of deliberateness with how you're approaching the referrals. Don't just send everybody to the same place, even if they have different preferences. But that also takes time. It takes like a level of um, that it's not something that should be rushed, even though crisis services also can have like a fast pace to it. So I imagine there's a little bit of a dichotomy or tension that's carried there where you really want to be intentional and deliberate with the time you're spending and with the referrals that you're giving, and yet there's a lot that may be asked of you in these working environments. So the next question is similar, but what extra steps must be taken by crisis providers working for different organizations to assure a good continuity of care? So by that, when I say different organizations, I mean you've got multiple behavioral health crisis service providers within the same community. Um, what what should what steps should be taken to make sure those relationships are strong and sustained? And Michael, we'll start with you.
I mean, I guess that goes to, just networking with your community, be in, professional associations. I know in my region that the county has a network of providers that actually has its own association. So being part of those associations, being visible, being present, connected with those other providers. I think personal connection goes a long way when it comes to trying to sort out the challenges of providing crisis provide type of work. So it's
So
it's building relationships.
okay. Can you lean into that a little bit more, Michael? If it's about the relationships, how does that manifest? Is it going to other organizations' team huddles and doing a presentation? Is it getting coffee with the person who's the same level as you in the organization? Like, what are those strategies for building those relationships? Think of people maybe who are even new to a supervisor role, who really don't have those relationships in place yet.
Sure. Yeah, it's actually deliberately setting the time that you're going to connect. So I know in my region here, you worked for the county as a crisis services lead, and we would actually facilitate provider meetings where we're going to have the youth mobile crisis team connect with the crisis line, so we could talk about what were the challenges of referrals or follow-up, or how to make referrals, or the response times. So set in those working meetings so that you could actually address things that come up, if they could wait until you had that meeting. So deliberately having those planning sessions, um, looking to the funding source to be that overseer of not so much scrutinizing the providers, but supporting the providers with the funding that they're providing to provide good quality care, but doing that together as a network of the crisis helpline, the mobile crisis provider, and even the crisis facility programs.
Okay. When I worked as a crisis residential provider, I would get frustrated in uh, um, community meetings that included a bunch of behavioral health providers at the table because it felt like we were always the focus of attention. We were serving some of the most difficult individuals in the community, and nobody seemed to be satisfied with how we were doing it. I guess I also wonder, how do you keep your poise or make sure that you can keep your guard down a little bit? Maybe it's not your guard just so much as your defensiveness. When these conversations might not just lead to you giving feedback to the other crisis providers, but them giving feedback to you about how your team is performing, and it might be as hard to hear for you as it is for them.
Yeah, that's a tough situation when you're hearing criticism in a public meeting about your team and you don't want to react. You want to learn from that. That's a very hard place to be in. And that's where the cup of coffee before the hard conversation is a good idea, where executives or peers will go and have that cup of tea and say, who are you and how am I supposed to feel about you? And so when you have those hard conversations later, whether it's about a critical incident with a confidential call on the side, or whether it's in a public meeting, that it's within the context of the work that you're doing and who you're trying to be as a person. So I would strongly suggest that one of the ways to get that continuum of care to work is to have those personal relationships and to be aggressive about making them happen.
Great. Thank you, Jason. I love what you said there, that preceding the conflict or the criticism with coffee and relationship development is going to help you to take that so much better. And people are going to act differently when you're with them one on one than how they are in a group as well.
Yeah,
And
our expertise here is in relationships. Let's use our strengths between each other and practice what we preach.
that's always the irony, Jason, is that we are experts at taking care of people, and then we don't do a good job of taking care of each other through candor, through honesty, those types of things. So, Miles, anything you want to add to that?
Yeah, I mean, it's so valuable to connect with the other providers, and I think of our own experience here. There's common pathways, and that creates opportunities for us to coordinate more closely. But I think of all of those other um, opportunities out there for clients, and we don't always know all of the options until someone's in our house or on our unit. And I mean, how can we bring all of those people together? It's always the time, it's the resources, but it's so important. There's turnover, people change, programs change. How do you stay on top of it? It's a lot of work, but invaluable work. I don't have any answers. I just thinking in my head, like, yeah, that is so important, and it's really hard.
I,
Hmm.
I do a lot of coalition building in the mobile crisis verse, and I'm routinely talking to mobile crisis program managers who have not met the their peer, another mobile crisis program leader who lives in their same city. They
Mhm.
haven't met them. They might know about them or know about the program, but they haven't extended the hand and gone over and said, "Hello, let's have that cup of tea." And the value there's another value I didn't mention earlier, which is that this is the person who knows your pain. who knows how you've been suffering. Your spouse doesn't know, your mother or father doesn't know, your dog can't figure it out. But this peer who is in another mobile crisis team or another residential service team or another crisis hotline, boy, they know the pain that you've been suffering and they will listen to you.
Empathy. It's a great point, Jason. Thank you for bringing that up. We are going to move on to our next question. How could health plans or counties incentivize better care coordination? Or really anyone that pays for crisis services if your community doesn't have health plans or county paying? How could they incentivize better care coordination?
I'll start with the obvious, especially since you just told me you're going to meet with my board after this. I think anytime you attach funding and connect the funding, agencies pay attention to connections and really work on improving systems of care. And I think often in systems we dole out money to agencies individually, but tying those together with some shared goals and some shared responsibilities really just helps us work more effectively together and in the long run helps our clients not fall through the cracks.
Okay.
Yeah, Travis, I would actually almost reframe the question a little bit to say not health plans or counties, but health plans and counties, and private
Mm,
insurance, commercial plans. Because I know in our region, like they're still struggling with how do commercial plans pay for crisis services. Because when it comes to crisis service, that crisis service is for anyone. Doesn't matter what their insurance is or if they have any insurance, we're going to serve them, we're going to meet them where they're at, we're going to help them. But then on the back end, we got to figure out responsibly how do we pay for that? And that's not just up to the local region or county or Medicaid dollars or non-Medicaid dollars. Like there's plenty of people in crisis that have insurance and coverage and resources, but we don't bill them. And that's a whole can of worms right there. And how do you do all that? But the resources got to meet the need, and we are expected to provide the service. So how do all of these health plans, commercial plans, counties, regions, the Medicaid system provide funding that's adequate to the helpline, to the mobile crisis team, to the residential program? It costs a lot, and so often in behavioral health we undervalue our services because we get paid the lowest rate possible.
mm.
Yeah, just resonate, Miles and Michael, and ambulances figured it out. We can figure it out. The other argument to take to both counties and health plans is the consequences of not coordinating, is that the injuries that they will end up paying for and hurt our, the funding in general even more than providing the care coordination.
I might ask you to each to speculate a little bit on this, but why do you think that commercial health plans are so behind the times when it comes to funding crisis services? It's very, go ahead, Jason.
I don't think they're behind the times. I think they've been very clever at evading it.
Hmm.
I
Tell
mean,
us more.
we've seen no, I mean, Michael's put his finger on it. We've seen no evidence of this coming together at all, and very little evidence of politicians or healthcare administrators making this happen. So I would say that they're not behind. They may be adjacent to, and cleverly so.
Hmm. Yeah, we just know that like across the country, for example, programs like the one that Miles operates, crisis residential programs, very few are covered by private insurance, commercial insurance, even though you've got the evidence behind it. You've got decades of research, you've got evidence of cost savings, improved client care. I'm not sure what else more you would want to be able to make a compelling argument, and yet they put most of their resources in emergency psychiatric care towards hospitals and partial programs. So it remains a mystery, but it feels like we could all do so much better. I say this often in front of audiences. I say, if you have commercial health insurance, you have a worse behavioral health crisis benefit than your peers who have no insurance or who have Medicaid in most cases.
But Michael says we're going to do it whether we get paid for it or not, which we are. We're sort of in this stuck position of being at the tip of the spear and not being able to say no.
Yeah. Yeah, I wonder how much of that has come from a mindset of nonprofit providers to do the right thing.
Yeah.
Even though doing the right thing isn't always a fiscally sustainable thing to do. But it would be wonderful if it invited other members of the safety net to also do the right thing,
Do you
including
think this is
payers.
a do you think this is there's a legislative solution here?
That's a good question. Sometimes the solutions do come through legislative advocacy. With, I don't know. I'll reflect that back to the group.
Yeah,
Yeah, I
that's
would
a
say
good
look at
question.
who's lobbying in Washington. I mean, that's where the decisions are made around what gets funded. And legislators don't know. They know what the people coming in the door are telling them. Hospital associations are probably a much more robust lobbying group than ours.
Yeah.
And
That's a good question, Jason, because in Washington State, there was a legislative bill passed years ago to say commercial plans will pay for crisis services, and they're still trying to figure out how to do that. So to your point, Jason, I think it's not like they don't bother to do it. They know what's happening. They know their members are in crisis and getting care because we're going to do it anyway. But other people providing the care, not the health plan, and then there's not a mechanism to communicate that back in order to incentivize the payment.
Hmm.
So still trying to figure it out.
I do know a few years ago there was some discussions at the federal level about trying to generate a bill that would allow Medicare to cover crisis services because they don't really have much of a crisis benefit. That would also change the landscape. But then we have to be careful of what we ask for because if certain payers come into this space, then you might see the landscape of the providers change, and you might see some opportunism come from folks who just want to make money off of services that really require the level of time and attention that we've been talking about.
Well, back to ambulances, there's a safety net there that if there's an indigent person who receives care from the ambulance may try to bill them, but they're going to get paid one way or another through the indigent fund.
Hmm. Right.
And that's what the model that we need. But I think, just going back to my point, we think we do need a legislative solution to this. And it's not going to come from the feds in our lifetime. It's going to come from states. Washington State is way ahead of the rest of the country in legislating good rules about mobile crisis. Mobile crisis workers are now considered first responders in Washington
Hmm.
State. Uh, but we need to lean on the states that can pass legislation now in this direction and make it happen.
Yeah. We're going to move to our audience questions, and I'm going to pull the slide down here in just a moment, just so that we can see the panel a little bit better. But the first question comes in from Jorge Lopez, and Jorge said, "What changes or strategic pivots could nationally operated crisis lines make to improve linkage to mobile crisis services when appropriate?" Michael or Jason?
So one of the things I was thinking about with the best practice around connecting crisis lines with mobile crisis is the tools they use because I know one of my last tasks when I was working for the county here in Washington State was to revamp mobile crisis. And in doing that, they brought on, and there's a lot of tech tools out there now that are used for dispatching. So using quality dispatching tools so that you seamlessly can connect that person in crisis and that caller to the mobile crisis team that's geographically located. So, to me, using the right tools is going to be key.
I think
Jason,
there's always
anything you'd like to add?
it's always the local issue is that often the list of mobile crisis teams that they may have at the national hotline is not really accurate. And whether there's you're sending people on a goose chase or not is always the question. So keeping those lists up to date and keeping the information accurate is the key.
Yeah. Okay. Um, Folks who are here attending, feel free to add your questions to the Q&A, and we will get them answered as they come in. Um, So I guess another question that comes to mind around care coordination is how do you all know if where you referred people was helpful? What's your feedback loop, and how do you monitor that for the people that you're serving? Do you do follow-up calls with them? Do you hear back from them in your customer satisfaction surveys? Like, what are some of those ways that the people you serve tell you whether what you gave them was helpful or not?
We just in January instituted follow-up calls. It's really carrying contacts with some calls attached to check in with people after, up until, and then after that they've connected to their next place to make sure that they get there and to make sure that they're okay and comfortable with the services they get. So that's what we're going to be using this year to help determine the clinicians who are working with the clients in the program are going to take on those responsibilities to do those very short calls. And so far, 3 weeks into it, it's been going, 4 weeks into it, it's going pretty well.
Okay, great.
Well, on a crisis line side, more and more call centers are implementing follow-up calls, especially those who are linked to emergency services. In fact, 988 has an expectation of doing that kind of follow-up, so that it's not just a matter of saying like, here's the referral and go do this, or we're going to pass you on to mobile crisis, but the expectation is then to follow up and document what happened next. Because if that referral didn't turn out to be helpful to the person, we want to make sure we do something alternate to that. It's actually part of the ICH accreditation standards to look at the follow-up process that a call center has in place.
Okay. And is it common that there's also funding attached to that, that you can pay people for the time that they are doing those follow-up calls, because since that takes them away from being on the lines?
That's a great question, Travis, because I think years ago there was always the desire to do follow-up calls, but yeah, there was no funding for it. I wouldn't say there's necessarily funding for it. I think centers are more creative of how to build it in to their system. I think 988 call centers are getting better funding for their call centers, so they're able to kind of build in like when are you actually going to make those follow-up calls or resolve those follow-up issues.
So when you say getting creative, does that mean using interns and volunteers to do those things, or what does that mean?
It could be that, or it could be like managing your phone workers' schedules so that they'll take time to do follow-up in between, and it's certainly training about how to manage your time, um, and also understand the culture and the importance of doing the follow-up calls because it's not only a matter of taking the next call, but follow up to make sure all of the other work is processed. So it's managing the workload for the call takers so that they're not overwhelmed.
Okay.
So in mobile crisis, more and more almost all teams at this point are keeping data about contacts, and more teams are being able to share that data online with the general public, and of course, other teams can look at it and see, some comparison about what's the level of service being provided. But I think Heather in the chat just put her finger right on the solution for mobile crisis. It's follow-up. And this is a sort of an ethos embedded in community mental health. This makes sense. It's not so much on the alternative response side, but it's definitely what we see as really improving service outcomes and the sort of reducing the amount of calling and people coming back over and over again to need services is doing that follow-up. And sometimes these follow-ups, it's not just one. You need sometimes to do several follow-ups before you're going to see that person not be out of their crisis. Crises don't end just because I show up. They sometimes take a little bit longer.
Yeah.
I'm going to stick in the chat a nice document created by Centerstone about their follow-up program. And it's really the national model, and everybody should take a look at this who's doing mobile crisis.
Great. Thank you, Jason. What I think all of this centers around is this idea is like, what if we really cared about the people that we were serving? And what if we, looked beyond just the immediate crisis and tried to do a little bit more? That's kind of what's happening in these regards. So it's encouraging, it's congruent, um, and maybe for some crisis providers, it's what we wanted to do all along, which was to see through the help that we could support. I think it was Myles that mentioned carrying contacts. If you want to learn more about the history or the epigenesis of carrying contacts, research the work of Dr. Jerome Motto. He was a psychiatrist who sent follow-up postcards to people who had discharged from a psychiatric hospital in California after a suicide attempt that refused further treatment. And he was able to reduce the suicide rate of those individuals by 50% just by sending postcards or letters to let them know that they were being thought about and cared for, but without an expectation that they needed to show up to another appointment or that they needed to respond or anything like that. Some very helpful research in this capacity. So I don't believe we've had any other questions come through the chat. So I'm going to bring, well, actually, maybe we did. We did. Here's a question. Would it be helpful for crisis lines to conduct a direct handoff to mobile crisis teams by contacting them directly and sharing information about the person in crisis?
Well, I think that happens in some places. I think every city seems to be different, unfortunately. Um, uh, we get a lot of calls for mobile crisis from 911 where it's not a direct dispatch, but the 911 operator says, "Aha, I think mobile crisis would work here instead of police." And they pick up their own cell phone and text or call the mobile crisis team leader at 3 o'clock in the morning. "Hey, could you help?" I think there's a lot of that going on. And then crisis lines, it seems to be different everywhere. What do you think, Michael?
Yeah, well, I know in my own region and the work I did to kind of revamp what this looks like is that this is actually exactly what happens. The helpline is the place where they're going to gather the information to pass off to the mobile response team so that they have the information they need, especially when it comes to safety. You want to make sure that they're going to walk into a safe situation, or if there are any safety issues, that they're aware of it. Using those technical tools to like dispatch immediately, because you also want to make sure that we're not putting a person in crisis in a position of retelling their story over and over again. They've talked to the crisis line, they gather information, passing it on directly to the mobile response team. Then of course they're going to go and on scene, and then they'll move further from there. Of course, they'll have to ask more questions to connect with the person, but I think a lot of this happens in a pretty seamless way, at least in my region.
Losing my mouse, my cursor. Yeah, those times that our 988 workers reach out to mobile, and then they'll reach out to CSU really before, after the 988 call, we can have a discussion about like the possibilities. So then when the mobile worker goes out, they already have an idea of like how this could all work out, and when it happens, it's beautiful. It works really well.
We have time for one more question, and this is from Amelia Leto. How do we make the crisis system feel continuous and supportive from the individual's and family's perspective?
I would say I always welcome feedback. Every family's different, and we try to listen. We've got a client who's in front of us who has particular needs. We have families sometimes who have opposing needs. Trying to pull all those things together in the most sensitive, humble way possible. It's challenging, but always open to feedback.
Yeah, I was going to echo this, Anthony Miles. I think it's a great question, Amelia, and one that's worth providers attending to. The challenge is that families deal with like three or more different providers that are operating according to their policies, their practices, and maybe there's differences in what that looks like, and so there's confusion to the families. I think for me, the best approach could be the idea of more community education. Let's educate our communities as to who the providers are, what it means to reach out for help when you're in crisis, and what different providers can do to help and make a difference.
Jason, anything you'd like to add?
Well, I was the NAMI director for Oregon for a while, and I always learned from the NAMI directors of Ohio and Washington State. But the family perspective is very special and very different than the individual perspective, and often they're much more interested in the urgency of making sure this person is safe. So that conversation about personal autonomy and versus safety is really essential. That everybody in the crisis world needs to be facile with this conversation, whether it's coming from the consumer, individual perspective, or from the family, law enforcement, institutional perspective. I would just suggest that people be aware of that conversation, be able to have it at the drop of a hat without any sort of anxiety or pressure.
Great. Myles, Michael, Jason, thank you so much for being our panelists today on this important topic. We really appreciate it. Just a few housekeeping items as we wrap up. CRA has 2 upcoming webinars, one on leveraging DBT across the crisis continuum. That's Wednesday, March 11th. And then Thoughts About Suicide, a cognitive behavioral therapy suicide prevention overview on Wednesday, May 13th. Follow CRA on LinkedIn for all of those updates. And also consider joining us. Become a member of CRA. We provide discounts on conference attendance, access to all CRA webinar slides and recordings, and access to a national listserv comprised of behavioral health crisis professionals. And lastly, CrisisCon 2026 is coming to Atlanta, Georgia, October 5th to 8th. More information will be available at crisiscon.org. But look for the call for presentations coming out in the next few months, as well as sponsorship opportunities, which are being made available very soon. If you have questions about CRA or about this webinar, you can email us at info@crisisresidentialassociation.org. So on behalf of our panel and CRA, thank you for joining us for today's meeting, and we hope to see you again soon. Cheers.